Hello, everyone. I'm Dr. Russ Dunkel, and I am the current Wisconsin State Dental Director, as well as having been in private practice and education for over 38 years in the state of Wisconsin. Dr. Joe Best and I would like to welcome you to the second half of our comprehensive training for dentists. One of the acronyms or terms you may start hearing and may already have heard in both the Journal of the American Dental Association and the Journal of the American Medical Association is the term or acronym NNT, which stands for numbers needed to treat. The definition of NNT is the number of people who must be treated by a specific medication for one person to receive at least a 50% specific effect. So delving into that further, the question with NNTs becomes, how many people must be treated with a certain dose of a medication for one person to receive 50% effective pain relief? An example is a product with an NNT of 1 means that the medicine is 100% effective at reducing pain by 50%. Another way to clarify that is if a medication with an NNT of 2 means that 2 people must be treated with the drug in order for one person to receive that same effective pain relief. And this graph kind of shows, or chart shows more specifically, kind of what we're talking about and how this helps you within your practice as well. If you look to the right, you can see that ibuprofen and acetaminophen, even at a 200 milligram dose of ibuprofen and acetaminophen 500, has an NNT of 1.6, which is excellent. As you go further over to the left, and you see on the far end, oxycodone, 15 milligrams, which is a significant narcotic prescription, only has an effective pain relief, especially for dental procedures, of 4.6. So we see that the ibuprofen and acetaminophen is significantly better in treating dental pain and especially anything that's related to inflammation. The other thing to consider with tramadol is even though it's good for people who may have allergies to almost everything, tramadol on this scale has an NNT of about 8.6. So it's definitely not as effective as ibuprofen and acetaminophen. We really want to try to concentrate on using those non-steroidal anti-inflammatory. What I like to do now is just kind of go into dentistry examining board guidelines. Some of the best practices for prescribing controlled substances are as follows. Before prescribing or dispensing, diagnose, assess risk, assess pain, review prescription drug monitoring program or PDMP, collaborate with other providers, especially physicians if needed, and then definitively treat the dental need. To delve into that further, that when prescribing or dispensing, we want to maximize non-opioid therapies. We want to follow an established controlled substance office policy. So this would mean checking the PDMP and sharing information with the patient, even if prescribing less than 3 days. Start low and go slow. In particular, we want to make sure we educate the patients, not only about the drug and all the potential side effects and other issues they should be aware of, but also what you want to do too is talk to them about realistic pain expectations. For example, if you're doing an oral surgery, it is surgery. There is going to be some pain. The patient needs to understand that. And then also follow up if acute pain lasts longer than 3 days. But I want to step back for a second and again talk about the PDMP. One of the things we've noticed is because you don't have to check the PDMP if you are prescribing narcotics for less than a 3-day supply. And that is great because it means that people are reducing their prescription practices for opioids at that level. So that is helping reduce the opioid problem. One of the things I want to pose though is that you still may want to check the PDMP because the fact there's so many drug to drug interactions that we need to be aware of it, especially when we're working with the patient and the patient's physician. So what you can do, and the DSPS will go into that shortly, is your office can establish, or you can establish a delegate account. And what that means is that you can go into the PDMP and you can pick either a trusted assistant, hygienist, or front office staff that can actually go into the PDMP on your behalf. And then they can look up the patient's prescription drug system, and they can actually print that out for you to review. So if you're very busy, you don't have to take the time specifically to do it, but at least somebody in your office can help follow with that. Next, I'd like to move into the PDMP, or the Prescription Drug Monitoring Program.
Hello, everyone. Welcome to this webinar on the Wisconsin Prescription Drug Monitoring Program. This webinar is presented to you by the Department of Safety and Professional Services. My name is Marjorie Liu, and I'm the Program and Policy Analyst for the Wisconsin PDMP. Before we get started, I would like to thank the Department of Health Services for providing this opportunity. The Wisconsin PDMP is a tool to help combat the ongoing prescription drug abuse epidemic in Wisconsin. By providing valuable information about controlled substance prescriptions that are dispensed in Wisconsin, we aim to aid healthcare professionals in your prescribing and dispensing decisions. This presentation will comprise 3 parts. First, I will introduce the components of PDMP, a bit of history, and regulations that impact your work as a healthcare provider in dentistry. Second, we will go through some of the ways that healthcare professionals have utilized ePDMP to enhance their practice by using resources and tools readily available on their prescriber dashboard. And finally, we will walk through the ePDMP account registration process before we wrap up the webinar. Without further ado, let's get started. What is the Wisconsin ePDMP, or Wisconsin Enhanced Prescription Drug Monitoring Program? In brief, a PDMP is an electronic database that collects prescribing and dispensing data on controlled substances. Through advanced analytics, the Wisconsin ePDMP turns raw data into reports that are immediately accessible, interactive, and easiest digestion possible. There are 4 components of the Wisconsin ePDMP. First, it is a clinical decision support tool that informs prescribing, treatment, and dispensing decisions of healthcare professionals. Second, it is an interdisciplinary communication tool between healthcare professionals and law enforcement who submit alerts and access ePDMP for investigation. And third, it is a prescribing practice assessment tool. Specifically, the prescriber metrics report serves as a tool for the prescriber's self-evaluation. It is also a tool for the medical coordinator to evaluate the prescribing practice of healthcare providers they oversee. And last, it is also a public health tool. The interactive statistics dashboard provides the public relevant statistics, such as the dispensing trends at the state and county level without the requirement of login. Here are some numbers that may give an idea about the analytical capacity of the Wisconsin ePDMP. Currently, the Wisconsin ePDMP receives more than 800,000 dispensing records per month and generates 80,000 data-driven patient history alerts per month. There are 55,000 active healthcare professionals users and 650,000 patient histories are queried per month. Now, just to be clear, a patient query is performed and recorded in the ePDMP when a healthcare provider reviews the patient's information in the ePDMP. Among the dentists, the majority of the patient queries is performed by those in the dentistry general specialty, which comprise 55% of all queries, followed by the dentistry surgery specialty, that is 44%. All the prescribers are now required by law to review PDMP data before they prescribe controlled substances to patients. The launch of the Wisconsin ePDMP in 2017 has optimized this process by saving invaluable time of healthcare providers. Among the milestones on this timeline, most notably is our integration with the EHR in 2019. It enables the users to review PDMP directly from their EHR interface, which has streamlined the process even further. In the next slide, I will talk about the HOPE legislation that mandates PDMP review of healthcare providers, among other requirements. Earlier this year, the PDMP requirements have been extended to the year of 2025. The Wisconsin Act 266 is PDMP focused and one of the 2015 HOPE agenda bills. In accordance with the law, dispensers are required to submit to the PDMP by the end of next business day, and the prescribers are required to review PDMP prior to prescribing a monitored prescription drug. The law also extends the PDMP access to 3 types of users, including 1, medical coordinators who oversee healthcare providers, and 2nd, non-prescribing healthcare professionals who work with patients receiving controlled substance treatments. And 3rd, law enforcement who may be authorized to access PDMP without a court order. Relevant to your role as a prescriber, there are exceptions to the PDMP requirements. They are, first, the patient is receiving hospice care. Second, order is intended to last 3 days or less and is not subject to refill. Third, drug is lawfully administered to the patient. Fourth, due to emergency, it is not possible to review the PDMP. And 5, PDMP is not operational or other technical failure. In the next several slides, I will touch upon the impact of the Wisconsin PDMP on enhancing the practice of healthcare providers, particularly the prescribers. In a survey done by the Department of Safety and Professional Services in 2018, a significant proportion of the participating prescribers have identified various actions they have taken after reviewing the Wisconsin PDMP data. The top 4 most notably actions taken, including, first, nearly 70% or 3,000 of the participating prescribers confirming that their patient was not misusing prescriptions. Second, over 63% or 2,600 of the participating prescribers spoke with the patient about controlled substance use. And third, over 50% denied or modified a prescription for a patient. And last, nearly 50% confirmed that a patient has other prescribers that the patient had not previously disclosed. These are just some of the ways prescribers have shared with us how the PDMP has positively informed their clinical decisions and practice. In addition to descriptive actions, statistically, we have also seen changes of prescribing and dispensing behaviors. The bar chart shows an increasingly downward trend of the overall dispensing in opiates and benzodiazepines for all professions in Wisconsin. In the past 6 years, opiates dispensing has a significant decrease of 34%, and it is a 24% of decrease for benzodiazepines. When breaking down to the most commonly prescribed opiates, the decrease in the number of prescriptions over the course of the 4 years is notably 40% for hydrocodone and 52% for oxycodone. The opiate prescribing trend of dentists in particular in the past 4 years is comparable with that of all professions. Among the common opiates, hydrocodone comprises the largest proportion of opiates prescribed by dentists, it has been a decrease of 50%, followed by the oxycodone prescription, a decrease of 43%. Next, we will turn to the Wisconsin ePDMP website and help you optimize your usage of PDMP as a healthcare provider. The prescriber dashboard is the landing page after you log into your account. Click on the icons on the menu bar, and you'll be led to the patient report, patient panel, alerts, practice metrics, delegate management, ePDMP usage, or medical coordinator management. In the next couple slides, we will walk through some of the most valuable functionalities in the patient report, alerts, and prescribing practice metrics. A patient report contains patient information, history of opiates, prescription locations, history details, MME calculation, and patient alerts. There are a few features on the patient report I would like to bring to your attention. Number one, the interstate patient query. After entering the patient's name and date of birth, you will have the option to set the query within the state of Wisconsin by default, or select multiple states for interstate PDMP data. Number two, the morphine milligram equivalence or MME calculator. With this tool, you will be able to select drugs and plug in quantities to estimate dosage. Number three, the expandable sections, such as the prescription history location and dispensing history details, that save space and loading time of the web page. This is one of the features in the new patient report design that was released in July 2020, based on user feedback. Number four is the patient alerts, for which we will turn to the next slide for a more detailed look. There are two places where patient history alerts will show. One is on the top menu bar, where an aggregated number of new alerts will appear. In addition, numbers of 3 different types of alert will also show on individual patient reports. The 3 types of alerts are, first, prescriber-led alerts. These are submitted by prescribers. And second, law enforcement alerts. They're submitted by law enforcement entities. One example of law enforcement alerts would be cases associated with diversion of prescription drugs. And third, data-driven alerts that are automated by the system concerning misuse or abuse of prescription drugs. These alerts allow prescribers to have an interdisciplinary perspective of concerning patient history prior to prescribing controlled substances. The last functionality on your prescriber dashboard we will look at is the prescribing practice metrics. The metrics provide a visualized, high-level analysis of your practice and your patients. You will be able to view your prescribing volume ranking among your peers in the same specialty. You will also get to view certain patterns of your patients, such as their payment type, their average distance traveled to obtain prescription drugs, and a summary of patient alerts. In the next section, we will take a quick tour of the ePDMP registration process. To register for a prescriber user account, go to the Wisconsin ePDMP web homepage and click Register. On the next page, select Healthcare Professional from the Account Type drop-down menu. You will then be prompted to enter your personal information, your license number, and license type. Click Lookup, and the registration form will appear with certain information pre-populated that are affiliated with your license number. Other information you will need to complete this form includes, first, your primary practice specialty, your DEA number, and employer information. Upon submitting your form, you will then be prompted to create a username and password. Click Submit upon completion. Next, PDMP staff will review your requests. Requests are reviewed on case-by-case basis. You may expect to receive follow-up communication with one of the following: an approval notification, request for more information, or denial. Once your registration is approved, you will be able to add or create delegates. A delegate is not able to register until a prescriber has created a profile for them. Your delegates will be able to access the Wisconsin ePDMP patient reports on behalf of you and print or download patient reports for you. A delegate can be linked with multiple prescribers, and you may add more than one delegate. Before we conclude the webinar, I'd like to point you to some great resources on the website. First, the statistics dashboard. The dashboard is a great tool for the public to understand the epidemic and dispensing trend. Various advanced analytics of aggregated data are available without the requirement of login. Statistics are updated monthly and quarterly. In addition, training materials are available under support, including a frequently asked questions section, printed user handbooks on the right column, and video tutorials for various users at the lower part of the page. Should you encounter any technical issues, the support team is available by phone or email. For more information, please do not hesitate to contact the PDMP staff. Below is our contact information. Thank you again for joining me for the presentation.
Well, welcome back, everyone. And I want to thank the Department of Safety and Professional Services for doing such a wonderful job on going through issues and flow in the PDMP. Our next segment or section is going to focus on the stigma in the clinical setting. In other words, how to provide the best care for your patients, judgment-free. So I'd like to begin with a quote by Dr. Jerome Adams, who is the current Surgeon General of the United States. "Addiction is a brain disease that touches families across America, even my own. We must all work together to address it with science, urgency, and compassion. Recovery is possible." And this is very poignant for Dr. Adams, as he does have, and has spoken of this several times, a brother who has actually been battling substance use disorders. So let's move right into it. Let's go over the definition of addiction. Addiction is a chronic, relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. And this is important. It is considered a brain disorder because it involves functional changes to the brain circuits. These are involved with reward, stress, self-control, the pleasure centers of the brain, and that these can last a long time, even after the drug has stopped being taken. So this effect can eventually go away, but it takes years sometimes for this to diminish. So to clarify it even further, it affects the pleasure centers of the brain very dramatically. So what happens is the opioid narcotics actually start affecting those neurosensors within that center. So what it does, it creates a circle or a cycle that they have to keep hitting more and more to get that pleasure effect. So things that normally might have been pleasurable, such as going to a fine dinner, going to an anticipated movie or play, or sexual encounters, these don't have the same meanings like they used to. And literally getting more and more of the narcotic or drug seems to be the only way to actually stimulate those centers. But again, remember, it is reversible given time. So let's get into some risk factors for addiction. There are three main ones. There's the genetic component, behavioral component, and the environmental component. And off to the side here, you can see early exposure to ACEs, which are adverse childhood experiences or events. Drugs and alcohol play a very important role in this. There's an increased chance for developing a substance use disorder when substances are started at an early age. I know here it's got listed the ages from 10 to 19, but we now know from scientific studies that the brain still develops up until age 25. So actually the window is from age 10 to 25, where the individual is much more susceptible to the effects of the narcotic on their brain development. So we need to be very cautious when prescribing, especially for that age group, for that particular reason. And I know this slide's a little bit busy, but it just kind of also goes into more about the biology and environment. So that genes can have an effect in it. Mental illness is key to remember. The age of first use, which we just talked about, how the drug is consumed. Everyone has a different sensitivity to the drug, so it's hard to predict that. Environment is critical. Chaotic home and abuse, parents' use and attitudes. Peer influences can have a significant effect as well. We all know issues in the past several years with cyberbullying, et cetera. This can play a role in as well. And even trying to attain social achievement within school, as far as grades or even athletic prowess, can have an effect as well. So some other risk factors for addiction. We spoke about genetics, and it appears that genetics can account for 40 to 60% of addiction risk. And we get back to the adverse childhood experiences or events, that 4 or more of these ACEs increase their risk for addiction by 50 to 66%. And that trauma and substance use disorders, it's been proven that 77% of people in SUD treatment report past trauma. Co-occurring mental health. Of the 20.3 million adults with SUD currently, almost 38% have reported a mental illness either before or after the addiction occurred. So this kind of leads into comorbidity. And what I want to do with the comorbidity is just mention the fact of the definition that is when a person has 2 or more disorders at the same time or one after the other. So you can see by this slide that 7.7 million have a co-occurring comorbidity of mental illness and SUDs. That's a dramatic population number, especially in my estimation. Trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting effects on the individual's functioning mental, physical, social, emotional, or spiritual well-being. Traumatic events are occurring before the age of 18. So that's the definition of an ACE. They include all types of abuse and neglect, as well as parental mental illness, substance use disorder, divorce, incarceration, and domestic violence. ACEs can also take the form of adverse childhood environments created by factors such as socioeconomic status, race, etc. And we mentioned before that ACEs can impact brain development. But again, like addiction, this effect can be reversed. So one of the concerns we have going forward is dealing with patients with dental pain. Most dental pain we all know is acute, although sometimes it can be chronic. The use of opioids to manage non-malignant pain now has 2 opposing arguments. On the one hand, we have those in favor focus on the ethical issues of not allowing patients to live with pain. On the other side, we have those against that focus on the issue of addiction and the societal problems that can result, which we're all aware of as well. So that gets us into the issue of managing dental pain. Things we have to do is to remember to maximize non-opioid therapies. We want to lean on non-steroidal anti-inflammatories such as NSAIDs, acetaminophen, and long-acting local anesthetics. When opioids are used, we want to remember to use a minimal amount and combine with non-opioid pharmacologic therapies to achieve greater relief and lessen the opioid need. And as Joe mentioned previously, prescribe no more than 3 days worth if at all possible. So what are some pain management considerations? What happens if a patient is indicated they are currently using specific drugs such as opioids, cocaine, methamphetamine, or even alcohol? What do you do? Some things to remember with anesthesia and treatment issues related to opioids. Always allow longer onset for the anesthetic to take place. Typically, they will not happen in the 3 to 5 minutes that we're normally used to. You may also want to consider use of anesthetic combinations. So instead of using just one anesthetic, 2 separate types of anesthetic, which can actually provide an increased benefit. You want to be conscious of the fact that nitrous oxide may not work as you particularly expect it to, and also sedation issues that you may not be able to get the same effect from Valium or Xanax preoperatively that you normally would. You also want to consult with the treating physician, determine if the patient is on a pain contract, and then it is really paramount that you contact that physician that's working with the patient on that pain contract. And again, we talked about check the PDMP. And this is again where that assigned delegate is allowable. It can be very beneficial to the practice. Some other issues of anesthesia and treatment are with stimulants such as methamphetamine. What you want to do is avoid dental treatment for at least 24 hours after the last ingestion. And you also want to limit epinephrine to as little as possible. With cocaine, you also want to avoid vasoconstrictors for at least 6 hours after the last dose. You also want to be aware of the fact that some people will have a cardiomyopathy issue that could be dramatically affected by using the anesthetic with the epinephrine as well. Anesthesia and treatment issues related to alcohol. We all know that there's a potential for liver and liver function issues. So therefore, we want to be careful that there may be bleeding issue risks during periodontal and oral surgery procedures. And even from a periodontal standpoint, we need to be cognizant of the fact that even our hygienists who may be doing deep scaling and root planing can be a very bloody procedure. So this can also be a factor that you need to be aware of. And always be aware of the potential risks when prescribing acetaminophen because of the diminished enzymatic function in the liver. So also what we want to do is we want to make sure that we're supporting these patients in recovery. So if a patient indicates they are in recovery, do not prescribe opioids unless there is no other medically viable option. That doesn't mean you can't manage their pain. Again, the use of the non-opioid alternatives, acetaminophen and ibuprofen, is ideal. Now, opioids, again, as we mentioned, are not as effective for dental pain as other medications or options. So again, always revert back to the NSAIDs. And again, if opioids must be prescribed, ask the patient to have a trusted person or relative administer them to them so they're not doing it on their own. What happens if a patient may not indicate that they are currently struggling with SUD or the full extent of their use? That becomes a very difficult scenario and difficult to ascertain. This is where sometimes the trauma-informed care approach encompasses all aspects of a patient's life experiences and can be very beneficial in determining how to move forward. Trauma-informed care, or TIC, is an approach in the human service field that assumes that an individual is more likely than not to have a history of trauma. TICs recognize the presence of trauma symptoms and acknowledges the role it may play in an individual's life. It's a program or organization or system that realizes the widespread impact of trauma and understands potential paths for recovery. It recognizes the signs and symptoms of trauma in all individuals and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeking to resist re-traumatization. And that's a real critical point at the end of trying to resist re-traumatization. So some of the things we want to do in supporting patients using trauma-informed care. Key is don't assume use or history of use based on appearance. Use appropriate language to avoid re-traumatization through the use of certain stigmatizing languages. So we really want to avoid that. Why many times we don't use the term addiction when we're dealing with these individuals. Recognize that patients will have different access to resources and then will therefore handle traumatic events differently. Treat patients as an equal and be sure to legitimize their concerns. This builds trust. Ask the patient if it's okay with them being touched before doing the examination. We again don't know what type of traumas people have been exposed to. Up next is, how do we have an effective conversation about SUDs? Your patient tells you that they have a history of substance use disorder or they are currently struggling with addiction. What do you do? The content of the next segment, we will be doing an interview with two individuals who will share their experiences through substance use disorder, recovery, and also how they are involved in the training of healthcare professionals on these issues. I would like to introduce Skye Bowman and Tanya Craigie.
Thanks so much, Russ. I'm Skye Bowman. I work as a therapist. I've worked primarily with people that have opioid use disorders, co-occurring mental health disorders, and complex trauma for the last 15 years of my career. And then I have also trained different people in the healthcare system, in the probation system, the police, on more effective strategies to interact with people with substance use disorders. And then I advocate at the state level for statewide laws that provide better access to service for people with opioid use disorder. Tanya, did you want to share what's been going on with you?
Yeah, my name is Tanya Craigie. I am currently working as the program manager for recovery coaching at Safe Communities of Madison-Dane County. I also have worked with people as a therapist and as a counselor for substance use disorders for the past 13 years, primarily with opioid use disorder, complex trauma as well, and relationship issues. And part of that work was working with healthcare organizations and the providers, receptionists, staff on reducing stigma in their healthcare organizations.
Well, super. Thanks for both of you for sharing that. Okay, let's get into some of our interview questions. And I'd like to start out with, when did each of you first notice signs of a substance use disorder?
I was pretty young when I started to experiment with substances. I was 12. And I was seen as the responsible one in my group of friends that, you know, if you were using too much, I would be the one to tell you, until I was introduced to heroin when I was 17. And at that point, my drug use escalated very quickly. But, you know, I do want to point out that even before I took my first drug, there were things that did put me at risk for addiction. And some of those things were just my genetics. You know, I have addiction on both sides of my family. I did experience trauma at a very early age. And that trauma, I think, really had a lot to do with me just not being comfortable in my body. And looking for something to kind of take that pain away. So, you know, we can say that, you know, my addiction began the first time that I did heroin, which was the first time that I really had problem use. The first time I experimented with a drug when I was 12, when I was a child and I experienced a trauma, or even at conception because I was genetically preloaded. So there's a lot of different ways to look at that question.
Tanya?
Yeah, I would have to say my experience is a bit similar as well. My first experience, my first memory at the age of 3 was being passed in between two moving vehicles on the interstate at 60 miles an hour between two parents who were under the influence and arguing over me. And so that was a very scary, tumultuous time. And from then on, I had early childhood trauma pretty consistently. And so the first time when I got inebriated at the age of 11, that experience at the time wasn't necessarily like I've arrived or this is the best thing ever. I was actually quite hungover the next day and felt really sick. I think it opened me up to agreeing to do things later on. By the age of 14, when I tried marijuana, that was the point where I had arrived. I finally could feel like I could be in my skin and be okay with life and not worry about who was going to accept me or love me. And then that just spiraled into more and more things for me later on, just trying to escape all and numb every feeling that I was having.
Thanks for sharing that, Tanya. The next question I want to bring up is something that we've discussed a little bit in the past, and I know you both love to respond to. And the question is addiction a choice?
So this is one of my favorite questions because it's one of the questions that I think that Tanya and I get to do the most work around. Tanya's answer to the last question, I think, perfectly describes the choice that Tanya didn't choose to have a family history and be genetically preloaded. She didn't choose to have a chaotic childhood. She didn't choose to have childhood trauma, but all of those things put her at greater risk of developing an addiction. And so the way that I really ask people to think about this question, because it is such an important question, and it's important for each person to come to terms with, but it really matters in the amount of resources that are available to people. If they are blamed for their actions, there are less resources. And if it's not seen as a choice, then there's more resources available to them. And that's just kind of the way that funding works. So, what I ask people to do is to think, whether or not they have ever tried a substance of abuse, whether that be nicotine, alcohol, cannabis, coffee, whatever it is, right? And if you have tried a substance of abuse, you tried a substance of abuse the same as most people that developed an addiction tried a substance of abuse. And the difference is that you weren't genetically preloaded. You didn't have trauma that you were trying to escape from. You didn't have a mental health disorder that was causing your life to be miserable. It wasn't uncomfortable to sit in your skin. And so when you tried that substance of abuse, legal or illegal, it didn't do for us what it did for you. And so, you had no need to develop an addiction because it wasn't solving a problem for you. Where those of us who, when we are using, and we're really in that uncomfortable situation where we don't know how to continue to live with the brain and in the skin that we've been given. If you can call that a choice, but to us it feels like it's a solution, and it feels like we don't have any choices. For people that have never struggled with a substance use disorder, I try to explain it almost like cupcakes, right? If you had a party it's somebody's birthday at work, and there's that tray of cupcakes that somebody brought in, and it's in the bake room, and you are on a healthy eating kick and you were trying so hard not to eat that cupcake, but like throughout the day while you're working, every time you walk past that break room, you're thinking to yourself, would it really hurt to just eat the cupcake, right? Like it would probably be okay to eat that cupcake. And, cupcakes, sugar are reinforcing in the brain. That's a self-reinforcing stimulant. But, but substance of abuse are way more self-reinforcing. So if you can picture that and then times it by 10, that's what those cravings feel like.
I don't believe that I ever thought that I made the choice to become addicted to a substance. I have done a lot of research on trauma and the changes that happen in the brain. And I think that there are some correlations between the way that substances interact with those changes in the brain. And most people I know, and myself included, started using at a very young age before my brain was even fully developed. And so that became a critical part, a critical coping skill for me to help me get through the day. And I don't know until later on did I ever use to die. I was just using to live, to figure out how to get through another day. And it was only until, there were resources available to me and people in my life that cared enough about me outside of, my family to say that there is another way to live and let me show you how.
So thank you very much for that. So what I'd like to go into next is basically your interactions with health professionals. So the first question would be, what has been your experience with health professionals, both from the stigma that you're trying to get them to avoid and also from a patient perspective?
I've gone to like some like pre-op, appointments where the person that's, going down the list, because, pre-ops have so many questions with them. And the person's going down the list and they're checking the boxes for me. And they're like, no, you don't have a substance use disorder. And I'm like, wait, yes, I do. So, I guess my advice to medical professionals is, is to think about your own bias and make sure that you're challenging your own bias. But then also to be present with the people that you work with. And don't assume that somebody does have a substance use disorder or doesn't have a substance use disorder based on what they look like.
I've had good experiences and bad experiences. I had some dental work done, and I'm in like the 0.01% of people where your implants can have something wrong. I have nerve damage from implants being placed, and in the beginning of that, when I went to a doctor, like in an urgent care setting, it was actually like a same day appointment, not my regular doctor. I was told by that guy that I just had depression and my pain wasn't valid and that I needed antidepressants. I was just feeling really dejected. And so I started bringing a support person with me to all of my appointments. I was at that point on a pain contract with my primary care provider. So she was prescribing long-acting opioids at that time because I almost ran my car into a semi on the way home from grad school one day because I was in so much pain. And the only thing that stopped me from doing that was that I have a little girl and I wanted to be around for her and take care of her. And so I went and told my doctor, that's what I was thinking. And she said, we got to try and get ahead of the pain. So she had started me on extended release morphine. And so when I went up to Mayo, the guy said, opioids typically aren't prescribed for nerve damage. They tend to not have the efficacy that you're seeking, and gave me some other suggestions. And then my doctor said, yeah, let's try these other ones. We'll try one at a time. And but I don't want to pull you off what's working for you for your quality of life at this time. I also see, providers a lot treating the people that I work with, very almost like they have like leprosy when they're seeking pain management. I recently had one of the recovery coaches who works in this health care organization where he presented to, in pretty extreme pain, be told that he was an addict, and they weren't going to give him anything when he was released from the hospital. And I don't really think that any provider should ever be referring to their patient in that manner by their diagnoses. But I also think that every person deserves to have their pain treated with their history in mind and in collaboration with the person that you're working with.
Well, thank you both for sharing that. Going in that direction a little bit further, in your work educating professionals on stigma and language and attitude, can you share some of the tools or training techniques you use with those health professionals to try to avoid going down that rabbit hole, so to speak?
So one of the things that I do is that I really teach the difference between guilt and shame. So guilt is an emotion that actually gets positive results. So if somebody feels guilty about something, if they feel like they've made a mistake, they'll look for ways to do better. If somebody feels ashamed, then behaviorally speaking, we're going to get the negative behavior over and over and over again. And so most people don't, unless you have some background in therapy or are a very emotionally astute person, you often don't understand the difference between guilt and shame. But guilt really is just feeling like you made a mistake, and there's things that you can do to prevent making mistakes in the future and to make it right now that you've made that mistake. Shame is the idea that instead of making a mistake, it's you that are the mistake. There is something inherently broken and wrong with you. And I think that once that light bulb turns on for practitioners, that, if I want people to, to feel judged and belittled and not want to be honest with me, and get bad results from the people that I work with, then I should shame them. And if I'd like to get positive outcomes and have people enjoy our relationship, then, letting them know that they made a mistake is fine. And then working on solutions to that together is fine. So it really is, it's such a little difference, but makes a huge difference as to how you're received.
So in certain populations, we have these terms of endearment, or these terms that we use to relate well to one another, or to become more of that community or identify a part of that community. So people in recovery tend to sometimes in certain circles call themselves an addict or an alcoholic, because that's how they identify as part of that community or in certain support groups that they attend, as well as taking accountability for that. And that's how they identify. But as I would not use certain terms to refer to certain populations in the same way that they would within their own communities, I wouldn't do it as a provider for somebody who identifies as a person in one of those communities. So even if I'm working with somebody and they prefer to call themselves an addict still, or they're still choosing to call themselves an addict, or that's how they identify themselves, I, as a provider, will still refer to them as a person in recovery, or a person attempting recovery, or a person with a substance use disorder, not as an addict or an alcoholic. The other thing is being able to ask questions and being comfortable asking questions. And so a part of that is having the rapport or the relationship to be able to do so. I've had better outcomes with working with people when I've tried to get to know them first, and really created an atmosphere of trust before going into making them share some things that they might not be comfortable with. And so in a doctor's office, it's very, I know that everybody's pressed for time, and we have, 15, 20-minute windows sometimes to see one person before we see somebody else. But that relationship really begins at the front door. It begins at reception, the way that a person is received at reception, the way that a person is treated, the way that a person is asked about their insurance, and all of that is relative to their entire experience within that office. And then on to the dental hygienist, and then on to the dentist. In a doctor's office, it would be reception, nurse, and the doctor. And so really all of their relationships are really going to be telling as to whether or not, when you're ready to ask a question of a person, whether or not they have a history of using harmful substances, that they might be honest with you about that fact. If they're feeling judged from the onset of the relationship at the front door, they're not going to share that information with you, and they're not going to feel comfortable. And then also, I've had people share with me when they're in the doctor's office that if a doctor runs by, have you used cocaine, methamphetamines, A, B, or C, they're less likely to be like, oh yeah, that, and that. But if a doctor asks a little bit more, like, do you have anything in your history that you want me to be aware of, or that you would like me to know, or any concerns about past substance use, then that kind of opens up this whole other door.
Well, thank you both for that. And it does also go even to the fact that even phone etiquette when you're first contacting the office makes a big difference too, and attitude and tone, etc. It all is a factor.
Absolutely.
So kind of as a final, are there any special considerations that you believe that dental professionals should consider in treating patients with SUD?
Often I know that, my daughter's 10, and within the next couple of years, she's going to need to get some teeth pulled so that her teeth fit together, so she gets braces. When her teeth get pulled, she might get prescribed an opioid. And that's a really vulnerable period of brain development through those teenage years. And so, especially before prescribing opioids to an opioid naive teenager, just doing, adding that screening so that you can understand, does this person have a family history of substance use disorder? Does this person, identify any hardships in their lives that might be seen as ACEs or as trauma? And that way you can just rest assured knowing that you've done everything that you can to not be the starting point of somebody's substance use disorder.
And on that note, I'd like to, again, thank you both, not only for all your work that you're doing and have been doing, but again, the courage to come on this and then literally go through what I know had to be some extremely difficult scenarios to relive through your life. Is there anything else in closing that either of you can think of?
I think that the message that I'd like to leave you with is that recovery is possible and is likely when people are given the tools and the support that they need.
I think that is a responsibility to check in with ourselves on what our internal biases are, as well as how can I help this person be holistically well. And so sometimes that is asking those difficult questions and holding space for somebody that might open up to you in a dentist's office, but then also knowing some resources where you may be able to get them some help if they do identify with you that they may have a problem and they don't know where to turn.
Well, thank you both for all that. And again, you are both shining examples of the fact that people can recover. There is hope, not only from substance use disorder, but ACEs, trauma. There is hope, and it is possible for reversal. You just have to be given the opportunities to be able to do so.
When speaking to your patients, using judgment-free language can help build the rapport between you and your patient, and also can make your patient feel more comfortable sharing information with you. Language can negatively impact the way that people see substance use disorder and by the people that struggle with substance use disorder. Framing what the public thinks about substance use disorder can be accomplished through judgment-free language, and it affects how individuals think about themselves and their ability to change. using judgment-free language prevents intentionally and unintentionally propagating stigma towards people with substance use disorders. So what we recommend in order to further that rapport with your patient and to be sure not to stigmatize them is language of recovery and hope. It respects the worth and dignity of all people by using person-first language. It focuses on the medical nature of the substance use disorder and the treatment, and it promotes the recovery process. And then it avoids any of those negative stereotypes through the use of slang and idioms. Here's a list of things that we suggest you do use. And I know that changes in language can be difficult, but as long as you're remembering person first, this is going to be a lot easier to kind of wrap your arms around. So alcoholic, addict, abuser, junkie is all labeling the person as the problem. And we want to make sure that we're labeling the behavior, this medical disease, that's the problem. So we want to say person with an alcohol use disorder or person with a substance use disorder. User, again, we're labeling the person. So individual engaged in risky use of substances, individual using substances for non-medical purposes. Abuse or habit, switch that out for substance use disorder or addictive disease. Opioid substitution or replacement therapy can have some negative connotations, so instead use medication for addiction treatment. Non-compliant, unmotivated, resistant, those definitely, there's a lot of judgment within those terms. We want to say that people opted not to, they have not begun, they're experiencing ambivalence about change, or they're not ready. So first, we really want people to know that recovery is possible. Medication for addiction recovery treatment is the gold standard and needs to be included in behavioral health models, and that barriers to treatment still exist, and we have more advocacy to do to remove those barriers. Some of the barriers to getting treatment of those with co-occurring substance use and mental health issues, more than half did not seek treatment for their mental health issues because of the cost involved. Almost 40% did not seek treatment for substance use because they were not ready to stop using. This is a quote from the former US Surgeon General, Dr. Vivek Murthy. Never forget that the faces of addiction are real people. They are beloved family members, close friends, and colleagues. They are us.